can you create a verbal patient simulation for myself? I am a paramedic. Could you give me a patient simulation where you test what I know and test, how I treat patients?
Sure. I'd be happy to create a patient simulation for you. Let's start with a brief background, and then I'll give you the scenario. You are called to a residential home for a 52-year-old male patient who is experiencing chest pain. The call was made by the patient's wife, who is quite anxious. When you arrive on scene, you find the patient sitting in a chair in the living room, clutching his chest. Patient presentation. Chief complaint, chest pain. History of present illness. The patient states the pain started suddenly about 30 minutes ago while he was watching TV. He describes it as a pressure-like sensation in the middle of his chest, radiating to his left arm and jaw. The pain is a 9 out of 10. Medical history. Hypertension, hyperlipidemia, type 2 diabetes, and a previous myocardial infarction 5 years ago. Medications: metformin, atorvastatin, lisinopril, and aspirin. Allergies: none known. Vital signs: blood pressure is 160/95 mmHg. Heart rate is 98 beats per minute. Saturation is 94% on room air. Physical exam: the patient is diaphoretic and pale. Lung sounds are clear bilaterally. There are no signs of jugular venous distension or peripheral edema. How would you approach this patient? What are your initial assessments and interventions?
All right, so what I'm going to do is first assess the patient's consciousness. So say, hi, how can I help you? Do you know where you are?
The patient responds, yes, I know where I am. I'm at home. My chest really hurts. Can you help me? He appears alert and oriented to person, place, and time.
All right, so as I walk in the door, I'm going to quickly look at his breathing, and I'm going to see if he's pale, or if I can see if he's having a hard time breathing, or his color, like his appearance. What can I see from the door as I enter?
As you walk in, you notice the patient is indeed pale and diaphoretic. His breathing seems a bit labored, with an increased respiratory rate, but he is not gasping for air. His color is concerning, suggesting poor perfusion.
All right, so now that I know that his airway, breathing, circulation is all maintained, I'm going to start to ask him what time did this pain start, and I'm probably going to get my partner to put on the monitors to get a set of obs, such as a 12-lead ECG and a SATS reading, and a blood pressure, obviously.
The patient tells you the pain started about 30 minutes ago. Your partner places the patient on the monitors. The 12-lead ECG shows ST elevation in the inferior leads 2, 3 AVF. Blood pressure is 160/95 mmHg. Heart rate is 98 beats per minute. Respiratory rate is 22 breaths per minute. And oxygen saturation is 94% on room air.
All right, so most of those things are looking good except for the ECG. Could I do a V4R on this patient? And while that's happening, I'm going to ask him about the aspirin that he's taking, how much he is taking, and make sure that he's had at least 300 milligrams within the last hour or so.
Sure, you can perform a V4R to assess for right ventricular involvement. As you do that, the patient tells you he takes a baby aspirin, 81 milligrams daily, and has not taken any extra aspirin today. The V4R shows ST elevation, indicating right ventricular involvement.
All right, so because it's right ventricular involvement, I'm going to be very careful with my nitrates. If he isn't allergic to aspirin or has any current bleeding or internal or bleeding wherever, then I'm going to go ahead and give him 300 milligrams oral, chewed, and then swallowed. I'm not going to give him GTN because this is a right-sided involvement. And while I'm doing that, I will myself or get my partner to prep a IV line and to then start going or finding out which hospital we are needing to go to, and start moving towards the ambulance because this is time critical.
You administer the 300 milligrams of aspirin and avoid nitrates due to the right ventricular involvement. Your partner preps and establishes an IV line. You inform the patient and his wife that you'll be transporting him to the nearest hospital with PCI capabilities. As you start moving the patient towards the ambulance, the patient says his pain remains severe. You continue to monitor his vitals and provide reassurance, emphasizing the urgency of getting him to definitive care promptly.
So while we are doing this, I'm going to consider giving him some morphine because he is still in pain and it is a STEMI. So I can probably give about 2.5 milligrams at a time, as long as he isn't allergic to morphine and as long as his blood pressure is above 90 systolic. I'm also going to attach the defib pads for transport.
You administer 2.5 milligrams of morphine to manage his pain, checking to ensure he has no allergies to the medication and that his systolic blood pressure remains above 90 mmHg. You also attach the defib pads in case of any sudden cardiac events during transport. The patient's pain starts to decrease slightly, and you continue monitoring his vitals closely as you proceed to the hospital.
Yeah. Depending on the local protocol, I could consider administering clopidogrel. However, that would depend on the system in place. I would also leave the 12 lead on so that I can keep on doing more 12 lead ECGs en route. I would then be driving with my blue lights to hospital.
That sounds like a solid plan. Depending on your local protocol, administering clopidogrel could be considered. Leaving the 12 lead on for continuous monitoring and performing additional ECGs en route is a good practice. Using blue lights to expedite transport to the hospital is also appropriate given the time-sensitive nature of the situation. Your focus on ongoing assessment and intervention demonstrates your commitment to providing optimal care for the patient.
If his blood pressure were to drop, I would give him a fluid bolus. If his saturation dropped below 93, 94%, I would also put him on probably some nasal prom O2. I would set him in whatever position is most comfortable. Have I missed anything?
You've covered the essentials well. In case of a drop in blood pressure, administering a fluid bolus is appropriate. And if oxygen saturation falls below 93 to 94%, providing supplemental oxygen via nasal prongs is necessary. Ensuring the patient's comfort by positioning him in a comfortable position is also crucial for managing his symptoms effectively. Overall, you've demonstrated thorough assessment and preparedness to address any changes in the patient's condition during transport.
Have I missed anything? Can you try and teach me something that I might not have done that maybe I should have?
One consideration you might want to keep in mind is the possibility of administering a beta blocker, like metoprolol, if it's within your local protocol and the patient's blood pressure remains stable. Beta blockers can help reduce myocardial oxygen demand and improve outcomes in STEMI patients. However, this decision should be made based on the patient's individual presentation, vital signs, and local protocols. It's also important to ensure the patient is not in acute heart failure before administering a beta blocker. Integrating beta blockers into your treatment approach can further optimize care for patients experiencing STEMI.
Cool, thanks. I appreciate the challenge.
You're welcome. I'm glad I could provide a meaningful simulation for you. If you have any more questions or need further assistance, feel free to ask. Take care and stay safe out there.